Alrighty. Well, let's make a start. So hi, everyone, and welcome to our CEIH Improvement and Innovation Showcase series. I'm Scott Poynton. I work at the CEIH as a user interface and user experience developer, and I'll be your host today. In this series, we'll be exploring the topic of improving healthcare through machine learning and artificial intelligence. Next slide. But before we do go any further, I would like to acknowledge the land that we gather on today is the traditional lands of the Kaurna people, and we acknowledge and respect their deep spiritual connection to country. We acknowledge the Kaurna people as the custodians of the Adelaide region, and that their cultural and heritage beliefs are still important to the living Kaurna people today. And I'd also like to take the opportunity to acknowledge other lands that people may be joining us from today. Before we kick into the presentation, just a little housekeeping. So the presentation is being recorded. During the presentation, please just keep your mics on mute. That would be appreciated. The recording will be stopped for Q&A time. And for Q&A, please do use your mic, so you can turn your mics on or use the chat function to ask your questions. And we do encourage you to turn your cameras on, because we would love to see your smiling faces. So for those of you unfamiliar with the Commission on Excellence and Innovation in Health, or the CEIH for short, we're the lead agency for innovation in healthcare in South Australia. And we love to bring consumers, clinicians, and other collaborators together to turn ideas into better healthcare. Our vision is together, let's create better healthcare for South Australians. And to do this, we're supporting the sector to come together to imagine new ideas for better healthcare. And we also acknowledge that better isn't always excellent, but we're committed to measuring what we do so we can understand the impact that any change is having. So the showcase sessions are every Thursday at 1 p.m. for the length of the series. Sessions, as I mentioned, are recorded and will be made available on our website, which is ceih.sa.gov.au. And we try to aim to keep these sessions simple and share work happening across the sector at any stage or level of success. We're not just showcasing, polished, ready to be published pieces of work. And while we do focus on work in South Australia, every now and then we do share a showcase outside of our state to sort of ignite and spark ideas. So if you have a story to tell, please do contact us. We want these sessions to be relevant to your needs and interests. So if you have any suggestions for topics for future series, we'd love to hear about those. So please do reach out and let us know. So look, we're really excited to bring this series to you and highlight some of the work happening across the sector in the very interesting and exciting space of ML and AI to really augment decision-making and clinical decision-making and improve patient care. So what we're seeing now is the full program of 4 presentations in the series running over November and December. Just a gentle reminder, if you haven't registered for all of the sessions, you still can. So come along to some of the other sessions as well. Today, though, we'll be hearing from Iain Bertram. Iain's a data scientist here at the CEIH, and he'll share his work on developing diagnostic tools for gen med patients with shortness of breath. I'll stop sharing and stop talking, and I'll hand over to Iain.
Hello, everyone. Thanks for joining us. I'm just struggling to spot where. Oh, there it is. Share the screen. Can we see it? Okay, so today I'm talking about a research project which is to look at diagnoses within general medicine within Adelaide hospitals. Yeah, uh, oh, there we go. Yeah, so I'm going to give an outline of the project, a brief discussion of my background, just to try to introduce myself, work through what I think is the most important about part of this project, which is the data selection and preparation, how we actually label data, which results we're using as part of the model creation, and discuss a bit about timeliness. Then I'll discuss the machine learning models we're using, the optimization and results, and possible next steps for this work. This work would not have been possible without the input from a large team. It's largely being carried out in collaboration with all the people in the clinical informatics division, where I work at CEIH, which is largely working through the data curation, determining appropriate data sets. My background is not medicine or even medical research. I'm a particle physicist in my past life, which meant there's a lot that I've had to learn, and I've had a great deal of help. We've also had discussions from clinicians who work with CEIH or the local hospital networks who've provided input on appropriate lab tests and what sort of vital signs should be included in the model, and sort of gotchas to look out for. This work is part of a larger funding from an MRFF grant. Any errors or misunderstanding are my fault and not anyone who's actually provided input. Okay, so yeah, the machine learning projects we're currently running at the Commission. Essentially, the goal of our work is to develop tools that can assist clinicians and healthcare workers to improve health outcomes. We're trying to leverage the large health data sets that are collected by SA Health, and this is where South Australia is quite lucky. The fact that most and soon all public hospitals will be in one health record really makes it a lot easier to build models and access information for research projects. So we've had, though, to curate the related data sets, mostly based around the hospital's electronic medical record, to create what we call patient journey data. And I know that in healthcare, that's a dangerous term. Journeys can mean lots of things at once, but in this case, it's largely looking at one individual hospital visit and joining the data up and trying to work out which data is related to the diagnosis we're making. In the long run, there's the prediction of diagnosis in general medicine. There's improved length of stay predictions, which largely at the moment being carried out by a machine learning person now, I think, working for SA Health in another capacity, but was working with the South Australian Local Health Network, Alex, who we'll be hearing from in, I think, 3 weeks. There's looking at the risk of additional hospital admissions for people who enter aged care, and sort of in the long run, look at making this sort of journey data available to those who have a legitimate interest so that we can reduce data development overheads for other research projects. Now, who am I? My background, I joined the Commission in February this year, so I've been working for a whole 6 or 8 months on analysing healthcare data. Before that, I've spent close to 30 years working as an experimental particle physicist on large experiments in Europe, America, and Japan, generally trying to research the structure of the proton and on looking at the differences between matter and antimatter. That's quite interesting moving from that background where I've worked on really big data sets where the size of the data set generally increases by petabytes per year, where the total EMR is sort of measured in tens of terabytes, just to give an out. But the difference is that particle physics data is largely complex, but very well organized. Since we design and build experiments from the ground up, we have a very good idea of what the data looks like at all times. And a lot of my work was based on modeling physical systems, based on computer simulations and analyzing large data sets. So I've lived in a world where the quality metrics are built in and enforced by design, which when you go to dealing with human systems where you're dealing with actual human health, it's much more complex. So I've been on a very steep learning curve. Before digging into the results, I just wanted to make a couple of comments on the language I'm using. I frankly hate the phrase AI. I don't think it's very illuminating, and the way it's used in media and general societal discussions is sort of everything from very simple statistical analysis all the way to magic God mode. So largely, I discuss what I'm doing as machine learning, which can be thought of as a range of techniques to allow computers to learn to perform tasks without being explicitly programmed in each step of the task. It's essentially using advanced statistical techniques to look for patterns in the data and use that to make predictions. It's quite a cyclical analysis technique. You go through a process of selecting data, cleaning and preparing the data so that it actually can be used by the machine learning algorithms, deciding which features are important and what to include. You train the model, run a validation where you run it on data that it hasn't seen before, and then say, oh, is it good enough? Return to the beginning and repeat until you have either decided that the problem is not soluble, or you have a sufficiently good model to actually propose rolling it out. So the analysis I'm presenting today is the idea of general medicine, which I've heard people describe as a dumping ground for every patient where they don't quite know where they should go. So it's basically anything that is not categorized specifically. A lot of elderly or complex needs patients. And the idea is to construct machine learning models for 6 broad diagnosis categories. This is the starting point and a proof of concept for the idea. These are sepsis, heart failure, pulmonary embolism, urinary tract infections, pneumonia, and COPD. The categories were selected in consultation with clinicians at the beginning of the project, which actually predates me joining the commission. And I'd just like to note that this model and project is looking at diagnosing patients who are sick enough to be admitted to hospital. And it's not about identifying sick people in a healthy population. So it's rather than trying to identify someone who is about to or becoming sick, it's saying, what does this sick person sick from? Now, at this stage, the use cases are somewhat ambiguous, but possible use cases, and we always welcome input from others on this, is to help flag cases that need urgent attention and help prioritize rounds for doctors, but also to, probably even more importantly, help flag secondary conditions that also need treatment. I think in a lot of professions, you're often focusing on the problem directly in front of you and sometimes miss the secondary problems that, if not treated immediately, would delay discharge from hospital. Then part of the goals of the overall research project, which is not just machine learning, but looking at actually improving health outcomes and treatment within general medicine, is to try and speed up getting to the most appropriate course of treatment. And in general, none of these projects are intended to replace clinicians of any type. They're there to provide cognitive tools to help reduce cognitive load on and reduce the amount of time needed per patient or to reach appropriate treatment. So at this point in the analysis, one of the tricky bits is which information available in a record system or a data system should be associated with a diagnosis. And essentially, we build what we call a patient journey from electronic medical record of what is called visits. Now, a visit, if people are not familiar with the hospital system, a visit is not a single visit to a building, but it actually is associated with care from a particular group or unit within the hospital. So when you arrive at the emergency department, for example, in this timeline, someone comes to the emergency department to be evaluated. That's the start of a hospital journey. And that would be that time spent in the emergency department would be considered one visit. And if you were then admitted to, say, a general medicine ward, that would be a second part of the visit. And if the general medicine then passes you off to surgery or some other service within the hospital system, that's a third part of a journey, but they're all each individual visit. So if you end up in hospital in the home. So we want to actually join all those visits together into one healthcare encounter. Each of these journeys we then label with diagnosis flags. These are ICD-10 standard diagnosis flags, which are assigned to each visit, inpatient visit at the hospital by professional coders after the visit is complete. And these are the flags which we use to label our data and train for results. We then attach observations and test results to our data set and then select encounters where the first inpatient admission is to a general medicine ward, as opposed to more complex cases where patients may come in for surgery and then require general medicine treatment, or other situations which are not quite appropriate for this research. Currently, we're selecting data from 6 different hospitals from essentially metropolitan Adelaide. The range of data that we're using it covers the usage of the statewide electronic medical record up until the 1st of April, and starting and really on the first date that complete records are available within that particular system. We're using this data set because essentially to avoid having to, well, we don't have full access to the previous systems on the different hospitals, and it allows consistent data usage and allows any tool that we develop to actually use exactly the same data as the tool was developed on. In addition, we have a validation data set, which the training doesn't see, which runs from the 1st of April this year until the 1st of October. This is data where the patient has been discharged and the encounter is complete and the admission date is within these date ranges. In the future, we're looking to include other hospitals as they are rolled out on the statewide EMR. So here's some data based on real patients, but not of a real patient, that gives an idea of the sort of hospital encounters a patient can have that appear. Each color block is what we call example journeys. The one highlighted in red is a general medicine encounter, which would be a candidate for this particular model. In this case, it is a sepsis patient, which this model is one of the data, similar to one of the data items this model is trained on. But as you can see, each encounter that if we look at them, you can have, for example, if we look at the bottom one on the screen, now here the actual journey starts, I think in this case, it's a Barossa Hills location. They appear at the emergency department, and it's a case where they then transferred to the RA. There'll be some gap between while that transfer occurs, and then they'll become an inpatient, in this case for orthopedic surgery. And all of those encounters are then joined into one journey for the purposes of an analysis. This would not go into the data set because it's a surgery one, but the two above it would, where you got different types of general medicine encounters. So each of those journeys, we then look at the data that's available at around the time of admission to ward or within the first 24 hours. So that basic personal characteristics, which is age, gender, and Indigenous status. If they've been to the emergency department, the triage category, the test results, which I'll discuss on the next slide, which includes observations of vital signs such as blood pressure and temperature. And we've looked at very generic tests. We want to avoid tests such as a bacterial culture, which suggests that the doctor is pretty sure it's sepsis and wants to know exactly which bacteria is causing the sepsis. That almost indicates by the existence of that test that the patient has sepsis. And by including that in the machine learning, it rather than actually being trained to use the results of the test, it's being trained to use the existence of the test. Generally, the number of cases, it just gives a feel. The total number of cases we're looking at is just under 42,000. And we have a range from pulmonary embolism, which is less than 1,000 cases, up to heart failure and pneumonia, which is 8,500. The more cases you have, the better the training is likely to be, just on a statistical numerical basis. I'd just like to show a couple of plots of actual data that we're using. In sepsis, a couple of really important indicators should be the temperature and systolic blood pressure. Essentially, these plotted here is for the patients is the first temperature and blood pressure taken after admission, whether that's ED or into the ward. The box indicates what is standard South Australian normal values. Values outside that box would normally give an alert, and the alert to the people treating, whether it's a nurse or a doctor, and essentially is a range of 35.5 to 38 degrees Celsius and 99 to 170 on the systolic blood pressure. The blue dots are people who were not diagnosed with sepsis, and the orange dots are people who were. And as you can see, there's a lot of patients who lie outside the normal box, and there's not a clear distinction between sepsis and other cases in these measures. If we look in a different type of plot, which is just a histogram or bar chart, we can look at a couple of other results which are actually important in a sepsis result, which is a C-reactive protein and neutrophils. The normal results, or results which are considered normal as opposed to high, below the dashed line. And again, you can see that these are all the general medicine people who had this test carried out. And you can see the vast majority of patients actually have abnormal results. We can see here, though, that there is some distinguishing characteristics, that sepsis tends to be higher than non-sepsis in this case. You can't clearly put a line on this graph and say, well, these are sepsis patients and not, but by combining a number of these measurements, you can start to separate the two samples. This is a set of test results which is not included, which are blood gas results, looking at lactate on the y-axis and the base axis. Again, the box sort of gives somewhat normal results with a separation of other cases. Now, in this case, we're not using blood gases because it's not always administered to patients, while the blood tests we're largely looking at are ones which are common blood test results. I'm not going to go through this in detail. These are largely the data that goes into the model. They're general basic blood tests and urine tests that take place for most patients on admission to hospital. The numbers given here are numbers that we use to replace missing measurements at the time of diagnosis. So if a patient, I don't know why this would happen, if a patient didn't have their blood pressure taken, we set it to a default normal measure. No, I'm not quite it probably means there's something gone wrong with the data, or the patient left very early if there is no blood pressure. But they're common blood tests rather than standard ones. and rather standard ones that most patients would take. So having them done doesn't really indicate a diagnosis. We then develop a machine learning model. In this case, the technical name of the model is a random forest model. If anyone has questions about that later, I'm happy to pull up a discussion of what that is. But in finding the best fit to the model, we essentially split the data into training and validation sets. This is the larger data set, and I've got two validation sets. One is just a fraction of the original data set, and the second one, which goes nowhere near the machine learning, is not used at this point. You then train and optimize the model by varying model parameters to obtain the best result, which in this case is by getting the largest number of a measure called the area under the curve. This blue line characterizes, essentially you're plotting what is called the true positive rate, which is how often, in this case, a sepsis patient, the machine learning model actually identifies them as having sepsis, and the false positive rate, which is how often the model identifies someone who doesn't have sepsis as having sepsis. Now, a perfect model will have a 0 false positive rate and a 1 true positive rate. In other words, it gets 100% of sepsis patients identified and with no non-sepsis patients being identified. So we want that blue line to get as close to the top left-hand corner as possible. In other words, maximizing the area under the curve, we measure that area. Now, if we had a model which basically tossed a coin, that would be the dashed black line from the bottom left to the top right. We train and optimize the model. For the purpose of seeing how well the model does, we've chosen you can actually choose an operating point in here. Because what we're doing is classifying. We're taking a patient and saying whether they have sepsis or not. And what we've decided is the true positive rate should be set to 85%. This is an arbitrary choice at this point. You can actually select a higher one, but the higher you select that true positive rate, the larger the false positive rate is. And if we choose an 85% true positive rate, we find by just reading off this graph that the false positive rate is 27%. Now, this is largely done, but essentially each patient gets what I call a score. In machine learning terms, it's called a probability. It's not what a statistician would ever call a probability, but essentially a score. You take all of the inputs, you run them through the model, and you get a score, in this case, between 0 and 1. And here we show on the bottom left, the red is the scores for people with sepsis, and the blue is the score for people without sepsis. You can then just basically add up all of the people there and find the point where 85% of all the patients who have sepsis are above a particular threshold. You can then count the number of people without sepsis, and that's your false positive rate. In this case, you would normally see this blue curve would be a lot higher, but I've actually adjusted this plot so that it's normalized to so that the sum is equal to 1 for both populations. On the right is what's called a confusion matrix, which largely just tells you the same thing once you've applied that 85% threshold. There's a bit of a rounding issue here, but 85% of the patients at the bottom left, that the true positive, it's the true negatives, which are at the top left, the bottom right, sorry, is true positives, and the false sepsis patients are the top right. So essentially you want that the diagonal from top left to bottom right to be as close to 1 as possible. We can then take which of the various tests are most important for separating sepsis from non-sepsis patients, and that actually makes sense at some level. C-reactive protein, which is related to fighting off infection, and you can run down there. None of these have a huge impact, and you actually need them collectively. That it's a mixture of blood pressure and temperature and various other measures. Now, triage category might seem an odd one, but largely it will relate to the fact that each triage category will match certain types of symptoms. And in this case, it's actually triage category 2 will relate to a set of symptoms which either doesn't say the triage category 2 means you're likely to have sepsis. It's just good for separating one from the other. Now, this is repeated for the other diagnoses. We go through 3 of the diagnoses: sepsis, heart failure, and COPD have similar false positive rates and similar area under the curve scores, which means that using this particular data set is likely to, sorry, my watch is just telling me what that is, have similar performance. Well, if you look at pulmonary embolism and pneumonia, you're actually getting much higher at around the 45 to 50% false positive rates, which means at least that model is likely not to be very useful. If you're identifying 85% of the patients, but 50% of your 40,000 are also being identified, that is not useful. And actually for the UTI, you're up at nearly 60% for false positive rates. And that is, UTI really does require additional information to make this model work. And that's largely what that's telling you. But there's 3 models there which we may be able to improve by modifying exactly how we look for the best quality model. To check that this is a reasonably robust, instead of using a random forest model, we use another common popular model, which is called XGBoost. That's a name. It doesn't have to mean anything. But largely we find that the model scores and the false positive rates are essentially the same. For some, the Boost model is better than the random forest, and sometimes it's the other way around. But it does say that they're largely statistically consistent, when it sort of tells you that these results are reasonably robust. To check that these results work, we then apply that the model, we take that model which we've trained on the data up to the 1st of April and apply it to the data taken between 1st of April and the beginning of October. And we then just apply the model to the data and see how well it does. We then find the true positive rate, which in the training data was set to be 85%. So we apply the same threshold to the same model, and we find that for sepsis, it's 80%, 87% for heart failure, and for COPD, 83%, which, given that we're looking at essentially a data set that's about a quarter of the size of the original data set, is reasonably close. And the false positive rates are largely the same, although a little higher in heart failure, which is something we should check on. I've only looked at these particular ones. These are the models which at the moment could be feasible for further testing. There wasn't much point in checking the other additional models. So this is where I'd like to finish up. Essentially, I believe this is a proof of principle demonstration that a machine learning model can be produced to help with diagnosis. At this point, we need to obtain feedback from the rest of the research group on what would be acceptable false positive rates for the various diagnoses. Now, this isn't a straightforward thing that someone like me who has no medical background can decide, because obviously different conditions have different risks associated with an incorrect diagnosis or missing a diagnosis. So some you've got more time to get right, while others are incredibly urgent. Now, we know that with sepsis, you want to react very quickly, but sometimes the treatment has risks, and jumping to a treatment when you don't, giving unnecessary treatments has to be considered within a patient safety framework. So we have to look at what are appropriate false positive versus false negatives and what is an appropriate level. We'd like to do some additional work where we look at when every patient is in hospital, doctors make lots and lots of written notes. And we'd like to look at matching some of the diagnosis information with progress notes to check when the actual diagnosis has been made. When it goes from being a suspected diagnosis to when a treatment starts, and look at that, and also look if there are more appropriate times to actually access the data to improve its timeliness. As if it's an infection that unfortunately started in hospital, including that person in a data set at the beginning of their stay will actually make things, it will muddy the water because they don't have the symptoms at that point. And over the next several months to a year, as more hospitals are included in the EMR, especially rural hospitals, we'd like to include that data within there, which will be a little more tricky as rural hospitals don't necessarily have the same breakdown of clinical groups, but certainly we want to include those to see if it's useful and also works outside of a metropolitan session. Thank you.
Fantastic. Thank you, Ian, for sharing today. Look, that's certainly a great example of how we can take existing data sets, and in this case, EMR data, apply ML models and create tools that augment decision making about, in this case, potentially life-threatening conditions. So fantastic. Look, that does end the presentation part of today's session, but we can open up now for some questions. After the questions finish, I'll ask you to complete a very short survey. It's 3 questions long. We're just seeking feedback on today's session, and we genuinely use this feedback to improve how we deliver these sessions and carry the showcase series forward. I've stopped recording, so don't be shy. If you have any questions or indeed comments or thoughts, please take yourself off mute, turn your camera on, and ask away.
Sorry, I can't see the presentation still on the screen. But my question is,